Just want to thank the organizing and scientific committee of the conference as well as HIV-NAT for the privilege to be presenting today. And today I'll be talking a little bit about challenges in HIV prevention in adolescents and young adults in the Asia Pacific. And over here you'd see a little pamphlet, from Action for AIDS Singapore, gayhealth.sg, for their Pink Carpet Youth Program. This is targeted at men who have sex with men aged 18 to 29 years old. And it says you're in a safe space. And I think being in a safe space is one of the key things that we really need to promote for adolescents and young adults in the Asia Pacific. And to that end, I'll explain why in the next few slides. So I've got no disclosures. In terms of, and to this end, firstly, I'll share a little bit about the roadmap for my presentation today. So firstly, I'll talk about adolescents and young adults and HIV in the Asia Pacific. Secondly, I'll talk about why adolescents and young adults, like why is there intensified risk and additional vulnerability for adolescents and young adults in the context of HIV acquisition. Then I'll move on to giving you some examples and illustrations of HIV prevention interventions among adolescents and young adults in the Asia Pacific, just to showcase, the work that's been going on in the region and to illustrate, the kinds of innovations that we can take on, in the region as well, before moving on to future directions for HIV prevention among adolescents and young adults. So for this first section, I'll give some operational definitions and a quick overview of the data. Conceptually, so adolescence typically refers to the period of human growth or development after childhood or prior to adulthood. But in terms of the data and how we measure it, I will adopt the UNAIDS definition, right? So in a lot of the publications, you will see that adolescents and young adults typically range from the ages of 10 to 24. These include individuals below and above the age of majority. Typically that involves parental consent if you are below. And basically from ages 10 and up all the way to 24, you would include in this categorization. Interestingly, also data from UNAIDS, if you look at the UNAIDS data book, children tend to be classified as those below 15 years old, and young people 15 to 24 years old, whereas adults are 15 plus. So, for the purposes of this presentation, I'll be covering, data as well as interventions that refer to the whole broad age range of about 10 to 24. So HIV in the Asia Pacific, I think we know that Asia Pacific as a region is highly heterogeneous in terms of our, the countries, the policies, the cultures, and therefore it is also reasonable to expect a highly heterogeneous HIV response in the region. Recently, it's estimated based on UNAIDS data that there were 260,000 incident HIV infections in 2021. And also alarmingly, of those infections, about slightly over a quarter of them are among individuals aged 15 to 24 years old. And when we look closer at that data, among those who are aged 15 to 24 years old, almost all, 99% of those new infections were from key populations and their partners. So key population in this context will refer to gay men and other men who have sex with men, sex workers, people who inject drugs, transgender people, as well as clients of sex workers and partners of these key populations. And so, in the context of this presentation, when we're talking about HIV prevention for adolescents and young adults, I'll be framing a lot of my, the sharing today around prevention in this population. So this is the part, around why adolescents and young adults. So I'm a sociologist by training and social scientist, and one thing that has been covered today earlier also is the idea of social determinants. And I want to really highlight how these kinds of social determinants place adolescents and young adults at intensified risks in the context of HIV. So I'll start off by sharing Joshua's story. So Joshua is someone in Singapore, and if you can look through this trajectory over here of Joshua's story, it will show you from different ages what had happened in Joshua's life. And I'm going to pair as well some of the different situations that Joshua has found himself in. So from the age of 11, Joshua became aware of his own sexual orientation. At that point in time, he was also trying to find a space to belong. And Joshua had used religion to try and find that space. However, Joshua also faced a lot of issues trying to fit in as a gay man in Singapore. And between hopping through different religious institutions, a lot of his peers told him that he should try and change and not be who he is. And Joshua became sexually active at the age of 14. through that whole experience also, there was inadvertent disclosure to his family about his own sexual orientation. And his family basically told him, we know a lot of gay men, have AIDS, and you better not come home with AIDS. And throughout that whole period, his own self-esteem took a beating. In school he was bullied, by other people for hanging out with a lot more women in school. Throughout that time, it led to a certain decline and a certain solace that he found in sexualized substance use. So he was actually introduced to substances or chemsex at the age of 17. Fast forward to the age of 20. Joshua had a risk exposure through a chemsex encounter. And what happened was that following that, Joshua had always been paranoid about HIV. Joshua also knew about the different HIV prevention modalities. So after that, he approached a GP for PEP. However, because of the context, Joshua felt really uncomfortable sharing about, his experience using drugs. Like drugs also heavily criminalized in Singapore. At the time, we also had 377A, right, which was the law criminalizing sex between men in Singapore. Thankfully, it has now been repealed. But back then, it also set the stage for being not too forthcoming about his own sexual practices. And based on that information, the GP basically recommended that I think since you don't know the HIV status of your partner, and based on the behavioral information that they're telling me, through the guidelines, I don't think it's strongly recommended that you take PEP. And basically, it will be up to you to take it if you want to. However, Joshua, at the age of 20, really lacked the funds as a student. He also didn't want to approach his family for these funds because it would sort of validate, what his parents had said about, you better not come home with AIDS. That kind of narrative gets validated. And so because of this experience, Joshua got HIV and suffered from mental decline, went through a deeper period of sexualized substance use, and had a lot of self-stigma around HIV. Joshua would also tell himself that because you have HIV, no one will ever love you anymore, and no one will accept you. And that culminated in drug rehabilitation for Joshua. So if you think through Joshua's story, I think you can see that there are a lot of social determinants and a lot of historical narratives as part of that story that actually lead to intensified risks of HIV acquisition, which is at the other end of the trajectory. I think a little bit about the WHO social determinants of health framework at this point, which is what you see on the screen here. And in the social determinants of health framework, you will see that the distribution of health and well-being on the right, in this case, HIV, it's also a product or a function of healthcare systems, and in turn influenced by one's material circumstances, biopsychosocial context, their own social position, and these are all embedded in a broader framework of policies, cultures, and norms. This also relates to one study that we did in Singapore, which I led. We interviewed men who have sex with men in Singapore, and we were actually trying to answer this research question. What are some barriers to HIV testing? And when we think about anticipated stigma, which was cited as one of the barriers, how does anticipated stigma manifest for people? And when we think about anticipated stigma, what it means is that you experience stigma in anticipation of it. So I don't want to go to the clinic because if I go there, I might experience stigma or discrimination. And this is something that a lot of people cited as as fearing. That's why we call it clinics as spaces of costly disclosure over here. And basically what we also learned is that people learn that they're deviant, and they don't learn that they're deviant at the clinic. So interventions that are taking place at the clinic level may not actually address anticipated stigma, because if you teach people to not discriminate, to not stigmatize people, actually what people are facing as a barrier is before they even get to the clinic. And what we are actually seeing in terms of the results is that through their own formative years as young people, because of the laws that criminalize certain kinds of behaviors, because of family context, because of bullying in school, because of religion, society, other areas of influence, they actually start to learn about how they are actually deviant through different forms of moralities. And through this whole process, it actually creates a barrier to even stepping into the clinic in the first place and being not engaged in care at all. If you cut it a different way, you will actually see that this is a socio-ecological model which has been presented in a couple of presentations earlier. And I won't go into detail, but you will see that a lot of different issues that young people, key populations in general, but also especially young adults and adolescents face, are stacked from the individual level all the way to the public policy level, as with Joshua's story. And one thing that I also want to point out is that we often talk about this in the context of key populations in general, right? But how about adolescent and young adults in key populations? There are issues of resource, there are issues of autonomy, and the lack of empowerment because you're younger. And this is something that, so I teach a course at NUS on aging as a social determinant. And actually, this image over here comes from the WHO. And it also tells you, from a life course perspective, one's intrinsic capacity changes over time. And one's functional ability, so functional ability is basically what's expected of you. Functional ability is a product of both your intrinsic capacity as well as your context, which helps you get to where you need to function. So this could include your family, like your structures, policies, and so on. But you could also imagine that for key populations who face stigma and discrimination, one's functional ability is up there, and it diminishes because of the lack of a structure or lack of context that is supportive. And if we are actually relying on data that comes from key populations who are not adolescents or young adults to develop our interventions, what we're trying to say is that we are trying to take our interventions that are developed for the right side of the curve and trying to shift it down to meet individuals who are actually on the left side of that curve over there. So the question is, would that work or not? And I think we will actually need more data from adolescent and young adults in the context of prevention. So enough about what I think. These are actually some messages from youth themselves, right? So the UN AIDS advocacy brief in 2022, putting young key populations first, was published in consultation with young key populations in the Asia-Pacific region. And these key barriers also reflect what I've already talked about, which include the uneven distribution of differentiated HIV prevention services for young key populations in the region. Some places are doing better than others, but some, it doesn't even exist, differentiated services. And where services exist, there are legal or policy barriers such as criminal laws as well as age of consent issues that make these services inaccessible. Stigma and discrimination always comes up, and you can imagine how it's further intensified for young key populations. And there are also structural aspects, for example, services that are not developed with a young people's schedules or needs in mind, or are not sensitive to them, rather. Something else that I also wanted to highlight is, when we think about services for young people, apart from HIV, there are other issues that come up. People are in their formative years, they also need mental health support, for example. And so the idea of syndemics comes in. And syndemics refers to, the synergistic interaction of two or more coexistent diseases or health conditions which result in excess burden. There are multiple epidemics that synergistically drive one another. And in the context of HIV, this could be violence, poor mental health, substance use, HIV, other STIs, and so on. And what it implies is that you can't really treat one without having to treat others. You have to address all of them holistically. One study in the region involving focus groups with young people and key informants also found, what are the barriers to achieving, this syndemic approach for HIV and mental health. And, a lot of feedback involves saying that, HIV and mental health services are currently delinked, and also there are many structural barriers that prevent the integration of HIV and mental health services. These include it reflects Joshua's story as well, the lack of family support, fear of disclosure, schools as spaces of social exclusion and discrimination, and also the lack of a structure or infrastructure and funding to support peer networks across the region. So at this point, second half of the presentation, just wanted to highlight some HIV prevention interventions very quickly in the region. I'll be using this framework that was proposed by Hosek and Petifor. This was a review of HIV prevention interventions among young people, adolescents and young adults actually. This was around the world, but I'll be contextualizing it into the Asia Pacific. So they highlight biomedical, behavioral, and structural types of interventions. Biomedical typically refers to maybe medical, clinical, or public health approaches that moderate biological and physiological factors to prevent HIV. The behavioral involves interventions that reduce or moderate or change behaviors associated with HIV risk. And the structural interventions address structural factors such as maybe food insecurity, poverty, education, and so on. And they actually recommend that we need to take a holistic approach in terms of biopsychosocial approach to addressing HIV prevention. There have been some amazing work going on in the region. For example, I'll be highlighting a few biomedical interventions in Thailand. So there are studies such as the COPE YMSM study, which involve combination prevention effectiveness approach for young MSM and transgender women who sell sex. And this combination approach involved a series of interventions such as HIV testing, risk reduction counseling, condom and lube distribution, as well as other STI screening. And one thing that I found really interesting is that PrEP was not compulsory as part of this project, but many people and young key populations wanted to be engaged in PrEP. And they also found high PrEP persistence among young MSM and those who were enrolled in the study, in spite of or because of vulnerabilities to HIV and other STI. There's another study by my colleague Nat Songtawisin, who also gave a lot of feedback and comments for this presentation. So just a very quick shout out over here. Basically this study looked at a randomized controlled trial among MSM and transgender women aged 15 to 29 years old. And what it did was it enrolled and recruited about 200 who initiated PrEP. It sought to evaluate a youth-friendly standard of care service with additional PrEP app, which I think was called Project Raincoat or something. Basically what this study found, even though the original intervention to evaluate the app, found similar levels of PrEP adherence, what I found was also astounding was that, PrEP implementation is actually feasible for those aged 15 to 19, and that people were interested in engaging in HIV preventions at that age. And even beyond the clinic level, at a public policy level, I thought it was also good to highlight how policies such as the treat at any CD4 count policy that was actually put in place in 2014 here had led to some changes in some of these HIV prevention data, right? So this study, which was a retrospective registry database study on youth living with HIV, actually found that following the treat at any CD4 count policy, there was an increase in ART initiation from 80% to 83%, and loss to follow-up decreased from 17% to 11%, with many starting ART earlier. So some behavioral interventions in the Asia Pacific, we've got also mobile apps. This was a mobile app that was developed in Indonesia, and this Rumah Sela app enrolled 100 MSM, 50 people who use drugs, and 50 transgender women aged 16 to 30. As part of this digital platform or this digital package, it involved intervention to increase HIV knowledge. There are behavioral interventions that were also integrated, and also thinking through some of the structural issues as well. And what it led to was it led to increases in HIV knowledge, reduction in sexual activities without condom use, uptake of HIV testing, and reduction of the use of used needles for those who report using drugs. And what this also shows is that integrating multiple prevention modalities actually through an app is feasible and potentially acceptable, and work can be done to scale such innovations up. This was done in Singapore, and it's a study that I led, which actually evaluated a web drama series targeted at young gay men and other men who have sex with men. And the approach for this wasn't necessarily entirely academic. It happened in AIDS 2018, right, in Amsterdam, where a Singapore team was sitting in the van, and I like to, we were saying that, there's this really awesome web drama series that's been rolled out, that we really want to evaluate, because the community really wants to know whether it works and whether it's just, just maybe a nice drama series to watch. So we got funding from the National University of Singapore to evaluate this study through a randomized controlled trial. Basically this study helped to promote intentions to test for HIV. And we have some supplementary data to suggest that it also promoted actual testing. It's just that this study coincided with the COVID pandemic. So we weren't able to really ascertain if there was actual testing, because testing dipped for everyone during that period. Just the last two slides on this aspect, there are also structural interventions that I want to highlight in the Asia Pacific. There are also human rights approaches, such as harm reduction programs in Malaysia. And I think this study that also sought to evaluate a voluntary substance use treatment program as opposed to compulsory drug detention centers, found that a lot of young men were engaged in this study. And beyond that, self-reported drug use levels decreased significantly among both inpatient and outpatient clients after enrolling in this voluntary program. So human rights approaches also can be part of structural interventions for key populations. And this last one on structural interventions, this was a cluster randomized RCT in India, to keep girls in secondary school and to delay the age of marriage and entering sex work. This is also an attempt to move away from cash transfers to a more sustainable model. And this cluster randomized controlled trial involved, I think, 80 village clusters across many different regions and targeted girls aged 13 to 16 years old in schools. The intervention was multi-level. It targeted schools, participants, families, boys, communities, officials, and the media. And while there were no statistically significant differences, in one region they found that that a lot more girls who were enrolled had completed secondary school, and they actually attributed the lack of a significant finding actually to the fact that across time, actually the outcome variable improved across all the different regions. So future directions, what can we do moving forward? Back to that report by UNAIDS from young key populations. These are some consolidated recommended action items from youth themselves, right? So the first thing is to focus on young key populations, funding, data that's disaggregated based on age for young key populations, inclusion, and also integration of services that beyond HIV, what are other things that matter for young people. Putting young people in their communities at the center of the response is important. Getting young people involved in the development of the services, as well as in the evaluation of services. Ensuring more equitable access to HIV services and solutions, including human rights approaches, laws, stigma, and more importantly also modernize HIV services and expand access. Simplify services, differentiate services for young people, and we know that there's a digital wave, but as we digitize, also making sure that the digital divide and digital ecosystems can support these kinds of digital innovations. Financing is also something to take note of, and because of COVID-19's impact, we have to be sensitized and aware of how COVID-19 may have further disadvantaged certain groups of young people or widen gaps. Last bit over here, we've done some work also at UNC Project China, where I'm a postdoctoral fellow to review digital approaches to engaging community as part of clinical trials. This is another way that we can engage young people, digitally. And special thanks to Dr. Wu and Professor Tucker, who were part of this, I think, APEC session where we talked about digital approaches to engaging communities. And this turned into a narrative review later on. And in this study, we actually found that decentralizing trials, through digital methods, digital crowdsourcing techniques to crowdsource ideas from young people, because they have quality suggestions to help develop trial protocols, to refine interventions themselves, as well as to thoughtfully use digital qualitative methods, including chat apps such as WhatsApp, WeChat, to conduct qualitative work in the context of clinical trials, because you might reach people that you might not have reached through face-to-face methods. So for example, in one trial that we're running in China, by using WeChat apps, I think about 60% of participants in these WeChat focus group discussions said that they had never participated in an in-person LGBT-related activity before. So, some people who might never want to be seen at a public space to inadvertently disclose their identities might be better engaged too. So this is myself and Dr. Mali, Gifty Mali. We did a review of participatory approaches to clinical STI services delivery. And very quickly, the youth can also be involved in many of these areas, right, of service delivery, including the planning of services that you can do through ideation workshops, crowdsourcing approaches, developing services together, in the delivery of services, evaluating of services. So there are also very innovative community scorecard approaches, right? For example, I know in Vietnam, they have, in one of the recent IS meetings, there was a study that showed, how communities can be involved in developing quality indicators as well as scorecards for clinics to improve services, and as well as community-led responses in the HIV response. This is my last slide. And I think life course perspectives are also important. So returning to Joshua's story, the reason why I'm so acquainted with Joshua's story is also because it's my own story. And for Joshua's story and my own story, basically, what I had the privilege of is to be initiated in care, after the drug rehabilitation point in time. But I also recognize that it is my own privilege as someone who has the means, right? I had come from a middle upper class family. I was able to access drug rehabilitation in Thailand. I was able to access HIV services in Thailand as well before being linked back to Singapore. And not everyone can access that. So key populations are also diverse in the means that they have to access some of these interventions. And because of that, initially while I had dropped out of school, I was able to continue my sociology major in my degree, get a PhD, and also be presenting here today. But I think this is also something that highlights, across the whole life course, what are some of the things that we can put in place in terms of, schools, in terms of families, in terms of policies to really, prevent the accumulation of risks for young people across time. And, in spite of that, are we having interventions that allow people to get access to, where we want people to be in terms of the HIV prevention outcomes they are aiming for. But yeah, thanks so much. That's my presentation. Just want to give a quick shout out to my team at UNC Project China, people from my NUS team, from the National Center of Infectious Diseases, where I'm a visiting research fellow as well. And for the privilege of being here. Thank you.